Sit up straight. Not performatively, actually straight, the way you were told to sit in school. Now notice what that costs. Notice the muscular effort required to hold that position. Notice how quickly the body begins negotiating with gravity, looking for shortcuts, trying to transfer the load somewhere less effortful. Notice that within 30 seconds of genuine upright sitting, the posture begins to collapse. Not from weakness, not from laziness, but because the architecture of the human spine was never engineered to hold a static vertical column against gravity without movement. The spine is a dynamic compression structure. It was designed for a world that required constant motion, constant load redistribution, constant change in the angle of its curves. What it was not designed for, what its geometry, its disc architecture, its ligament orientation, and its vascular supply all reveal when examined closely, is the one posture that modern humans now hold for an average of 9 to 13 hours per day. The seated position at 90 degrees is not a neutral resting state for the human spine. It is, from the perspective of spinal biomechanics, one of its highest stress configurations. And the evidence for that is written into the physics of the structure itself. The lumbar spine, the 5 large vertebrae of the lower back, designated L1 through L5, is the load-bearing foundation of the entire upper body. Each lumbar vertebra is considerably larger than the cervical vertebrae of the neck or the thoracic vertebrae of the mid-back, and this is not coincidental. Size in bone is a response to mechanical demand. The lumbar vertebrae are large because they carry more compressive force than any other spinal region. Between each pair of adjacent vertebrae sits an intervertebral disc, a structure roughly 40 mm in diameter and 10 to 14 mm in height, composed of 2 distinct zones. The outer zone, the annulus fibrosus, is a lamellar structure of collagen type I fibers arranged in concentric rings, each ring's fibers oriented at approximately 30 degrees from the horizontal, alternating in direction between layers. Think of it as a bias ply tire made of biological tissue. The inner zone, the nucleus pulposus, is a gel-like core with a water content of approximately 80 to 85% in young adults, held in its hydrated state by proteoglycans, large molecules with the same osmotic property as a sponge, drawing water in under tension and releasing it under compression. This hydrostatic nucleus is the key to how the disc distributes load. When you stand, the compressive force from your upper body presses down on the nucleus, which cannot be compressed itself. Fluids are incompressible, and so it distributes that force radially outward into the annulus fibrosus, which resists it with tensile stress in its collagen rings. The disc is not a cushion in the simple sense. It is a hydraulic pressure vessel. Now consider what happens to that pressure vessel when you sit. Alf Nachemson at the Sahlgrenska University Hospital in Gothenburg, Sweden, was the first researcher to directly measure intradiscal pressure, the pressure inside the nucleus pulposus, under different body positions. His pioneering studies from the 1960s and 1970s, and subsequently refined measurements by Wilke and colleagues at the University of Ulm in Germany published in the journal Spine in 1999, established the intradiscal pressure values that now define spinal biomechanics. Standing upright, the pressure inside the L4-L5 disc in a 70 kg adult is approximately 0.5 to 0.7 megapascals. Lying supine, flat on the back, the pressure drops to approximately 0.1 to 0.24 megapascals. Sitting unsupported at 90 degrees with the hips and knees at right angles and no lumbar support, the intradiscal pressure rises to approximately 0.9 to 1.1 megapascals, higher than standing. Not lower. The disc under a seated spine is under more pressure than the disc under a standing spine. Wilke's 1999 measurements, using a miniaturized pressure transducer implanted directly into the nucleus pulposus of a volunteer, confirmed and extended Nachemson's earlier data with greater precision. The numbers are not disputed. Sitting compresses the lumbar disc more than standing. The reason is the geometry of what happens to the lumbar curve when you sit. In the standing body, the lumbar spine has a natural lordosis, a forward curve convex toward the front of the body. This curve is not decorative. It is an engineering solution. A curved column under compressive load distributes that load across a larger cross-sectional area of disc material and positions the nucleus pulposus centrally within the annulus, where its pressure distribution is most even. The lumbar lordosis positions the line of gravity close to the axis of rotation of each lumbar segment, minimizing the moment arm, the perpendicular distance between the line of force and the pivot point, which is the mechanical variable that determines how much muscular effort is required to maintain a given position. A small moment arm means the muscles work less. A large moment arm means they work more. The lumbar lordosis, when properly maintained, creates a moment arm for gravity that is nearly zero. The spine is close to being in mechanical equilibrium without muscular effort. When you sit at 90 degrees, the pelvis rotates backward, posteriorly, because the hamstrings, which cross both the knee and the hip, are put into tension by the angle of the knee joint. The average person, after years of sitting, has hamstrings too short to allow a 90-degree hip angle without posterior pelvic tilt. The pelvis tilts back. And when the pelvis tilts back, it takes the base of the lumbar spine with it, rotating the sacrum posteriorly and flattening or reversing the lumbar lordosis. The lumbar curve straightens. In many people it reverses into kyphosis, a backward curve. The nucleus pulposus, which was centered under lordosis, migrates posteriorly within the annulus as the front of the disc space narrows and the back opens. The compressive load, which was distributed evenly across the full disc cross-section, now concentrates on the posterior annulus, the very region where the spinal nerves exit the vertebral column. Intradiscal pressure rises. The posterior annular fibers are placed under asymmetric tensile stress. The ligamentum flavum, which runs along the back of the spinal canal and is normally taut under lordosis, buckles inward under kyphosis, encroaching on the space available for the spinal cord and nerve roots. This is not a chronic exposure problem. This is the geometry of every minute you spend seated in a typical chair. And the disc cannot tell the load has shifted. It responds to pressure. It does not report location. But intradiscal pressure is only the first mechanism. There is a second operating at the same time, and it runs through a completely different system. The intervertebral disc is the largest avascular structure in the adult human body. Avascular means without blood vessels. No capillaries penetrate the disc. No direct arterial supply delivers nutrients. The cells of the disc, the chondrocyte-like cells of the nucleus and the fibroblastic cells of the annulus, receive oxygen and glucose and eliminate metabolic waste exclusively through diffusion, the slow movement of molecules across a concentration gradient through the cartilaginous end plate, the thin plate of hyaline cartilage that sits between the vertebral body and the disc above and below. Diffusion is a slow process governed by Fick's first law. The flux of molecules is proportional to the concentration gradient and inversely proportional to the distance they must travel. The center of the lumbar disc is approximately 7 to 8 millimeters from the nearest vascular supply in the vertebral body. At that distance, diffusion alone is borderline adequate even under optimal conditions. The oxygen tension at the center of the adult lumbar disc, measured by Urban and colleagues at King's College London, is approximately 5 to 10% of atmospheric partial pressure. The cells of the disc nucleus live on the edge of anoxia under normal circumstances. The system that assists diffusion is mechanical. When the disc is compressed, fluid is squeezed out of the nucleus through the end plate into the vertebral body. When compression is released, the osmotic pressure of the proteoglycans draws fluid, and with it dissolved nutrients, back into the nucleus. This is the disc's pump mechanism. It depends on cyclical loading and unloading. Movement compresses the disc, rest decompresses it. The fluid exchange occurs at the transition. Standing, walking, and postural shifts create this cyclical variation. Sitting, particularly sustained sitting with minimal postural change, maintains the disc in a state of near constant compression. The pump cycles slowly or stops. The diffusion gradient that delivers nutrients and removes metabolic waste stagnates. Lactic acid, the end product of anaerobic metabolism in the disc cells, accumulates. The pH of the nucleus drops. Holm and Nachemson, in studies published in Spine in the 1980s, demonstrated that disc cell metabolism is critically sensitive to pH. Below approximately 6.8, cell viability and proteoglycan synthesis decline sharply. Sustained sitting is not a neutral state for the disc. It is a metabolic stress state for a tissue that has essentially no other way to receive nutrients. This is why disc degeneration correlates with sedentary occupations in epidemiological literature, and why the correlation is not fully explained by age. The disc is degenerating not because it is old but because its supply chain has been cut. Now I want to think about the hip flexor because the third mechanism operates entirely outside the spine and yet ends up expressing itself there. The iliopsoas, the compound muscle formed by the iliacus and the psoas major, is the primary hip flexor. The psoas major originates on the transverse processes and vertebral bodies of L1 through L4, the same lumbar vertebrae whose discs we have been discussing, and inserts on the lesser trochanter of the femur. This is not an ordinary muscle attachment. The psoas does not merely cross the hip joint. It is woven into the architecture of the lumbar spine itself. When the psoas contracts, it does not just flex the hip, It simultaneously exerts a compressive force along the lumbar vertebral column and, depending on the angle of hip flexion, can either maintain or disrupt the lumbar lordosis. In the standing position with a neutral pelvis, the psoas pulls on the lumbar vertebrae in a direction that helps maintain lordotic curvature. In the seated position at 90 degrees, the femur is fixed and the psoas is held in a shortened, partially contracted state. Sustained in this shortened position for hours per day, the muscle undergoes the same adaptive shortening that any skeletal muscle undergoes when consistently held below its resting length. The sarcomeres, the contractile units of the muscle fiber, are added or lost depending on the chronic operating length. A chronically shortened psoas loses sarcomeres from the end of its fibers, reducing its resting length. This is not pathology. This is normal muscle adaptation. It is the same adaptation that makes a cast immobilized limb weak and shortened after 6 weeks of immobilization. A shortened psoas when the person finally stands cannot fully lengthen. It pulls the lumbar vertebrae forward and downward, creating or exaggerating lumbar lordosis when erect, not from strength but from the inability to elongate. This excessive lordosis in standing increases the shear force at the lumbosacral junction, particularly at L5-S1, the most heavily loaded disc in the spine. Shear force, a force directed parallel to the disc surface rather than perpendicular to it, is the load configuration the annulus is least equipped to handle. The collagen fibers of the annulus are oriented to resist compression and tension. They resist shear poorly. A tight psoas standing up is exerting a force on the lumbosacral disc in its most vulnerable direction. The chair shortened the muscle. The muscle is now deforming the disc from the outside. The chair is gone. The damage continues. And here is where the story changes because the fourth mechanism is not mechanical at all. It is vascular, and it begins the moment the back of the thigh contacts the seat pan. The popliteal artery and vein pass behind the knee. Their upstream branches, the femoral artery and vein, run along the inner thigh, passing through the femoral triangle and adductor canal before reaching the knee. In the seated position, particularly in a standard chair whose seat pan is at approximately 45 to 50 centimeters from the floor, the thigh rests horizontally on the seat, and the seat edge contacts the posterior thigh approximately at the level of the popliteal fossa or slightly proximal. This contact exerts a compressive force on the soft tissue of the posterior thigh. The femoral vein, which is the low-pressure return vessel carrying blood from the lower leg back to the heart, is particularly susceptible to this compression. Veins, unlike arteries, have thin walls and low internal pressure, and they collapse under external pressure more easily than their arterial counterparts. Compression of the femoral vein reduces venous return from the lower extremity. Blood pools in the leg. The calf muscle pump, which during walking actively compresses the deep veins of the lower leg with each muscular contraction, generating a pressure of approximately 200 millimeters of mercury during walking, is completely quiescent in the sitting person. The combination of seat edge compression and absent calf pump means the lower extremity vasculature during prolonged sitting has significantly reduced blood flow relative to standing or walking. The consequences of this have been measured. Thosar and colleagues at Oregon Health and Science University published data in 2015 in Medicine and Science in Sports and Exercise showing that 3 hours of uninterrupted sitting produced measurable brachial flow-mediated dilation impairment, a standard marker of endothelial function, and that this impairment was prevented by a 5-minute walk every hour. The endothelium of the femoral artery specifically was the focus of a 2014 study in experimental physiology by the same group. 3 hours of sitting reduced femoral artery flow-mediated dilation by approximately 52%. 52% reduction in endothelial function in a major artery, not over months, not over years. Over 3 hours of ordinary seated desk work. The mechanism is shear stress. Vascular endothelial cells require laminar blood flow, the shear force of blood moving along their surface, to maintain production of nitric oxide via endothelial nitric oxide synthase (eNOS). Nitric oxide keeps the vessel wall compliant, inhibits platelet aggregation and maintains vasodilatory tone. Reduce blood flow velocity, reduce shear stress and eNOS activity falls. The endothelium stiffens. The vessel loses its ability to dilate in response to demand. This is the same molecular mechanism implicated in the development of atherosclerosis, not as a long-term risk factor but as an immediate physiological response to sitting still. The chair is not slowly raising your risk. It is changing your arterial function in the time it takes to watch a film. Now I want to step back and think about what all of this implies about the design of the structure that sits in these chairs. Bramble and Lieberman at Harvard University published a landmark paper in Nature in 2004 titled, endurance running and the evolution of Homo. Their analysis of the fossil record, the length of the Achilles tendon, the size of the gluteus maximus, the stabilizing muscles of the shoulder and neck, the size of the semicircular canals of the inner ear which determine tolerance for head movement, showed that the modern human body carries the anatomical signature of a distance-running animal. The gluteus maximus in particular is disproportionately large in Homo sapiens compared to our closest relatives, the chimpanzees and gorillas, whose gluteus maximus muscles are relatively small. Chimps do not need large gluteus maximus muscles because they do not run. The muscle is recruited primarily during running, not walking, and almost not at all during sitting. In the sitting position, the gluteus maximus is essentially inactive. The muscle that defines the posterior anatomy of the human body, the largest single muscle in the body by mass, is completely switched off by the chair. It is not merely resting. The absence of contraction in a muscle under sustained load leads to what exercise physiologists call neuromuscular inhibition. The motor units of the gluteus maximus are chronically under-recruited, and the motor pathways that activate them become less efficient. The result, described clinically as gluteal amnesia, a term coined and popularized by Stuart McGill at the University of Waterloo, is a gluteus maximus that has literally become less capable of contracting powerfully when called upon, not because it is weak in the traditional sense but because the nervous system has stopped rehearsing the command. The gluteus maximus is the primary antagonist of the iliopsoas. When the gluteus maximus is inhibited and the iliopsoas is shortened, the pelvis loses its primary stabilizing couple. The anterior tilt control from the psoas and the posterior control from the glute are in chronic imbalance. The pelvis is being held in a position by soft tissue tension rather than active muscular balance. The spine sitting on top of that pelvis is being asked to manage load distribution without its foundation. This is what 9 to 13 hours per day in a chair is building, not over decades but over months. Here is the part of this story I find worth dwelling on. The chair, as a widespread domestic and work object, is extraordinarily recent. Thrones and ceremonial seats existed in ancient Egypt and Greece. Chairs were objects of power, not utility, used by rulers and gods in artwork and ritual. In most cultures throughout most of human history, the floor was the primary resting surface. Squatting, cross-legged sitting, kneeling and reclining were the positions of rest, work, and eating. The squat, in particular, deep dorsiflexion of the ankle, full flexion of the knee, full flexion of the hip, maintains the lumbar lordosis far more effectively than chair sitting. The deep squat requires and maintains the full length of the hip flexors, the full range of ankle dorsiflexion, and the active engagement of the posterior chain. Gordon Hughes at the University of Colorado published a systematic ethnographic survey in American Anthropologist in 1955 documenting resting postures across cultures globally and found that the deep squat was the default resting posture in the majority of non-chair-using cultures, used by children universally before chair culture eliminates it. Western adults who have used chairs throughout childhood typically cannot achieve a full deep squat without falling backward, because they have lost the ankle dorsiflexion and hip flexor length that the squat requires. The loss is not genetic. It is acquired through the chair, a few degrees at a time, 1 year at a time. The Romans had the sella curulis, a folding stool for magistrates. Medieval Europe had benches. The high-back chair with 4 legs became a domestic object across European households in the 16th and 17th centuries as woodworking techniques advanced. The desk chair, the ergonomic office chair, the car seat, these are 20th century inventions. The chair as universal furniture, the chair as the default position for working adults in developed economies, is an experiment of approximately 1 to 2 centuries of industrial society. The body in that chair carries the anatomical residue of 3 million years of upright locomotion, ground-level rest, load-carrying, running, and squatting. Every disc, every lordotic curve, every femoral vein, every motor unit of the gluteus maximus was calibrated to a world that included none of the things the chair represents. Stillness, 90-degree hip angles, sustained posterior pelvic tilt, unloaded gluteal musculature, stagnant femoral blood flow. The mismatch is not subtle. It is measurable at the level of intradiscal pressure, disc pH, endothelial nitric oxide synthase activity, sarcomere count in the psoas, and motor unit recruitment efficiency in the gluteus maximus. These are not risk factors projected across a population. These are things happening inside a specific body, in a specific chair, right now. Go back to the moment you tried to sit up straight at the start of this. What you felt, that effortful contraction, that negotiation with gravity, that tendency of the posture to collapse, was not a personal failure of discipline or strength. It was the structural response of a lumbar spine whose geometry does not permit static vertical loading without movement. It was the posterior pelvic tilt pulling the lumbar curve flat as the hamstrings reached their shortened limit. It was the nucleus pulposus shifting posteriorly as the disc space narrowed in front. It was a diffusion gradient beginning to stagnate. It was the femoral vein beginning to experience reduced flow. It was the gluteus maximus going quiet. You felt all of that in the first 30 seconds. The spine was telling you, in the only language it has, that it was not designed for this. The body does not complain in the moment of sitting. It complains hours later, the next morning, across months and years, in the language of disc herniation and stenosis and lower back pain that now affects approximately 577 million people globally, the leading cause of disability worldwide according to the Global Burden of Disease study published in The Lancet in 2018. The spine encodes its objection slowly. It was built to move. It is still asking to.